Hey, thanks for organizing this, and Dr. Louie, thanks for having me here. I see a lot of familiar names here. I'm going to talk about vascular surgery for the ABSITE. As you can kind of see from this picture here, there's a lot to vascular in terms of diagnosis, surgery, follow-up, and I try to break it down to some reasonable bite-sized things that you guys could take for the boards there. So, does it go on to the next slide?
You want to put it in presenter mode on the bottom thing, sir? Is that easier?
Yeah, that'll be a lot better, yeah.
Okay.
There you go, is that? Okay, great. So, it's a small percentage of your test, only 4% by weight. And last year I said, it's a small percent, so it may not matter for you. But I think, this year you guys have done a lot. You've gone through COVID. You've treated a lot of difficult things. I think go for it, that extra 4% this year. You're going to get it after this talk. So the principles of vascular surgery, all right? Strike first, strike hard, no mercy. So I break up the vascular into a couple groups here. Arterial disease, this is all like the SCORE curriculum. They want you to know about the ultrasound, endovascular principles. But basically, for arterial disease is the bulk of it. And I split it up into aneurysms and occlusive disease. And that's really the bulk of what we treat. The occlusive disease is mostly atherosclerosis. There's a couple compression syndromes that they want you to know about. And then there's venous disease. Apparently, they ask about varicose vein stuff sometimes and May-Thurner syndrome, so we can mention that. And then vascular access for dialysis. And then I noticed that in the trauma section, they have a fair amount of vascular as well in terms of abdomen, extremities, neck, and thorax. And they mentioned fasciotomy, so we can kind of touch on that. Just the basics of the artery makeup and its anatomy, just so we can refer to, I'm sure you guys know from med school, with the intima media and adventitia. Just most importantly, the adventitia is your strength layer. Atherosclerosis is mostly what we're treating, and these are the stages of atherosclerosis, but you can see these, first few levels of atherosclerosis occur in your first decades of life, and we're dealing with people, 60 plus, so we're all talking about fibroatheroma and all these complicated, lesions that you see inside the vessel. Ultrasound. I don't think that there's much to it besides, knowing that that it is a good non-invasive test. It is relied upon heavily in vascular, and it's measuring velocity as a marker for stenosis. So a 50% decrease in the diameter of a circle is a decrease of 75% in area, and that is critical. So all these different criteria, I listed some below here, are all just ones that we use as a marker for stenosis. This one below is the most important one in that it's for carotids, and because that's the most well known, and so might be something useful for you. But peak systolic velocity of 125 and 230 are the two that you need to know that correlate with the degree of stenosis of 50% and 70%. ABIs and PVRs, another non-invasive test, but for the legs, and it kind of classifies the levels of peripheral arterial disease. 0.9 is the lower limit of normal, and then once you're getting to 0.7 to 0.5, starting to get more severe, and then you're talking about critical ischemia below that. And it can be done easily with a blood pressure cuff and a Doppler, and it's very reproducible. The waveforms that you hear on the Doppler on the ward, checking the pulses. Triphasic means it's a healthy muscular artery without calcinosis. Biphasic and monophasic don't really mean much beyond that clinically. It's just weaker sound over time, and you lose that directional flow, and in multiple collaterals converging on that Doppler probe at one point makes a monophasic sound. And then we look at the visceral arteries as well. I think, I'm not sure if they test you guys on this or not, But, the critical number for stenosis in the renal artery is a peak systolic of greater than 180. For the mesenteric arteries, we do this usually as a fasting test. Celiac is greater than 200, or SMA is greater than 275. And the celiac goes to the liver bed, which is a solid organ, so it's a low resistance sound all the time. The SMA is only low resistance during eating or postprandial. When you're fasting, it's high resistance because the muscular artery is constrict. And then just in terms of, they want to know, about endovascular intervention and its principles. I would say mostly they're saying, how not to harm someone with endovascular. Here's a picture of the Angioceal closure device in the back wall of the femoral artery. Case I did, interventional radiology put it through and through the wall and shut down the artery. And there's the suture that we're pulling out from the closure device in the femoral artery. So, you have to be careful. You have to know your endovascular principles. So we'll just go over the endovascular principles really quickly here. Access, that's really what it is. That's where it all comes down to, is arterial access. And to the right here is the first case I had as an attending. I put a blue circle where the femoral head is, and this is a morbidly obese woman. Cardiologist put a access, which you can see where the arrow is, where their access is, right in the common femoral artery. But the point that they missed, that even though it's in the common femoral artery, it's not over the femoral head. So you can't compress that. So there's a massive aneurysm that then developed into a arteriovenous fistula, and you can see blood shunting at the femoral vein. So the green arrow here is pointing to the femoral head. That's where you want to go. If you go too low, this is what you're going to get. And if you puncture below the femoral head, you're going to get pseudoaneurysms. The blood can't really go anywhere, so it just creates a pseudoaneurysm in the muscle in the leg. If you go too high, that's extremely dangerous, because then you're getting a retroperitoneal hematoma, and you might not see anything. You might not see bleeding. Just the patient becomes hypotensive, tachycardic, and massive bleeding in the retroperitoneum. So right over the femoral head is the important part. And then for radiation safety, you are using radiation, and so they have instituted these practices called as low as reasonably possible. But if they ask you anything on the test, it's really just increase your distance from fluoroscopy if you can, because that's the most effective, because radiation drops off exponentially with distance. But also using appropriate shielding in the OR lead, decreasing the time and doses that you're giving, and that, not going over an hour of radiation, because the patient's going to get deterministic effects, skin burns, and everyone's at risk for cancer in the room if you're not using your shielding correctly. And then we use a lot of contrast nephropathy, usually 2 to 5 days after administration. We usually don't see it in vascular, but it is something to be aware of. Okay, so our first disease process here is aneurysms. That's an aortic aneurysm repair. What is an aneurysm? It's a vessel that's 1.5 times the normal size of a vessel, and it involves all the layers. Ectasia is just that area in between normal and aneurysm, so less than 1.5 times the diameter. And pseudoaneurysm is exactly that. It's a false aneurysm. It does not contain any arterial wall layers, and it's basically a contained rupture. So the etiology of the degenerative of the aneurysms, most of that we see are degenerative and multifactorial, genetic, and rarely infectious. The risk factors are important. Smokers, anyone that was a smoker should be screened for aneurysm, age, male, COPD, and then importantly family history, which presents a high risk of rupture. And the natural history of aneurysms, most people think rupture, but that's really the central aneurysms of the thoracic and abdominal aorta and iliac arteries. But the peripheral aneurysms, mostly the femoral and popliteal, have thrombotic complications. So thrombus builds up in the wall of the aneurysm and then showers down as emboli to the feet. Abdominal aneurysms is an annual risk of rupture. We treat them when they're asymptomatic at 5.5 for most men, greater than 5 for female, or if you have any of those other risk factors, which are COPD, family history, or uncontrolled hypertension. So, 5.5 though is the number that people always stick to. If they're symptomatic or infected, or if they're growing rapidly, which is defined as greater than 1 centimeter in a year, then we treat them. And treatment options are open, endovascular, and something else that kind of came to light with our major trials for aneurysm repair, particularly the EVAR2 trial, is if a patient has less than 5 years life expectancy, then their outcome is the same if they have no surgery. So, no surgery is an option. That is major aortic surgery, and not everyone's a good candidate for it. For the open repair, the considerations are, the ischemia to the organs that are distal to your clamp. So suprarenal clamp time, you want to keep it less than 35 minutes. Supraceliac, also, high risk of death with that, and organ malperfusion. And then repairing the iliacs if there are, aneurysms there. And you can just see here this surgeon is delicately moving the duodenum off of the aorta between his two fingers, but in reality it's pretty rough on the surrounding abdominal organs, and so there's a lot of outcomes that are and complications that we'll kind of go over related to the surrounding surgery, not just the exposure of the arteries. And then the IMA is always a consideration because it's one vessel that's not routinely revascularized, and so the IMA you would take it and intraoperatively you would ligate it, or you would open the vessel and look at it. And when you think about it, you're trying to assess whether you're going to reimplant the IMA or not. The IMA is only really reimplanted if there's poor bleeding in it. So if there's pulsatile bleeding coming back from the IMA, you can put a clip on it or oversew it. If there's poor back bleeding from the IMA, that means the collateral flow through the marginal artery of Drummond and arc-real-an is compromised, or if the patient's had a prior colectomy, just reimplant the IMA. In terms of, what's the best repair for someone, and someone just asked, there's also endovascular is another, way to treat aneurysmal disease. So the EVAR1 trial, which I kind of alluded to, was that the EVAR1 was comparing open versus endovascular, and basically there was not a significant difference between the patients that had open versus endovascular repair and good risk candidates, and that's related to the complications of endovascular aneurysms. But we'll go over who is a good candidate for both, because there's more subtlety to that. It's not just that everyone's the same with open and endovascular. You have to really choose who's going to get your open repair and who's going to get your endovascular repair. But if it's a young patient with a straightforward aneurysm, they'd probably do better because they're going to live so long with an open repair. And in terms of the back pressure for the IMA, no, there's no specific back pressure. It's just if there's brisk bleeding that's judged by the surgeon, then it can be ligated. Some of the complications, though, this is for non-ruptured aneurysms. For open repair, you can see there's some pretty major complications here, which is why there is such a big push for endovascular repair. Respiratory failure, particularly pneumonia, is the largest complication. And traditional teaching was the patient's intubated for 3 days during their recovery, and that's no longer the case. There's aneurysms that are extubated immediately post-op now, but it's still respiratory failure and pneumonia is a major complication from the surgery. Heart attacks, leaking, renal failure, colonic ischemia, and that's related to the assessment of the IMA, which I think is important to know for you guys. If the patient has a bowel movement immediately post-op after an open aneurysm repair, and particularly if it's a jelly red, then you know that there's colonic ischemia. The subclinical incidence of colonic ischemia is very high, anywhere from 15 to 30%. But but the symptomatic ischemia is pretty low, and elective repair you see here 0.2 to 6% reported. but you would do, patients usually in the ICU anyway, immediately post-op, do a flexible sigmoidoscopy. If there's ulcerations in the colon, usually supportive care with fluids and antibiotics is enough. But if it's transmural ulceration all the way through, really the patient should be diverted and have an ostomy. Take out the ischemic segment of usually sigmoid colon, and otherwise they do poorly and have infected grafts. Lower extremity ischemia is very rare. Spinal cord ischemia is pretty rare as well, particularly because there's so much collateral flow to the spine if you're just doing abdominal aorta. But if the patient's had prior aortic surgery, such as the thoracic aorta, the IMA, and those lumbars are important and have to be considered. Late complications, the patients develop pseudoaneurysms, degeneration of the anastomoses over time, so they should have a 5-year CAT scan for follow-up after open repair, graft infection, graft occlusion from atherosclerosis, and renal failure. So EVAR, that came on the scene in 1999 for us in the U.S. And, it sounds like they actually, want you to know a fair amount about EVAR in terms of who's a candidate for it. A lot of this has to do with just the anatomy and the CAT scan itself. So the most important number that they have is the neck length, and the neck is defined as the distance under the renal artery, distal to the renal artery, proximal to the aneurysm. So a healthy portion of aorta, that's letter C there, and that has to be placed at 15 millimeters is a really conservative number. There's grafts that go much shorter than that, but for the testing purposes, 15 millimeter length neck is the minimum. Neck diameter, 30 millimeters, and that still holds true for the most part, is as wide as you can go for a neck diameter. Angulation, you don't want it to be too angled, otherwise the graft won't sit well and it will leak around the top. And then neck thrombus, meaning there's a lot of mural thrombus, a clot around there. If you have too much, the graft won't sit well. Again, it will leak. The common iliac artery length has to be 10. That's just really how the graft's made. And the common iliac artery diameter has to be large enough that you can get your sheath, so it's at least 8 millimeters, and small enough that you can seal it with a graft, so it's 18 millimeters. There are alternatives to that, but that's for a standard aneurysm, that's true. And then you want to consider your hypogastrics, whether you're going to cover them or not. Remember, you're also covering the IMA, so if you cover the hypogastrics, there's colonic ischemia, bodic ischemia to contend with. And then,
Dr. Bada, I just tried to interrupt you, Sarah. There are some questions in the chat function. I'm not sure if you can see them.
Yeah, I saw another question just came up.
Okay.
The questions are popping up as we're going. I'm trying to kind of answer them as we go.
You're more than welcome to answer them at the end if you want. I just wanted to let you know.
No, yeah, I just saw one pop up about infected aneurysms and rifampin soaking. It's a good idea, and we will talk about it because it's. I think the complications are more what you're tested on probably than the surgery itself. So we will get to the rifampin. Okay, so endoleak. I think they want you to know about endoleak, and I think it is important because it's the primary mode of failure of endovascular aneurysm repair.
Dr. Bada, I think your sharing screen ended.
Oh. Yeah.
Sorry.
How's that?
I can't see anything yet.
Oh. Did it come up yet?
Not yet, sir.
Oh, here it comes. Nothing?
Not yet.
Hmm.
There you go.
All right. All right. You guys see that, the endoleak? Okay. All right. So a high rate of endoleak, 15 to 30%, but not all of them are important. Only type 1 and type 3 must be repaired. So type 1 and type 3 are where it's leaking from above. Type 1 is where it's leaking from above or below. The seal zone is not intact. And type 3 is a junction, so between the pieces it's leaking. And you can imagine that's antegrade flow, so it's a massive leak from that. Type 2 is where you have retrograde flow through the IMA or the renal artery. What's that? No. Is where you have retrograde flow through the IMA or lumbar artery. And that's type 2. And then type 4. Sorry, I think someone's still not muted. Okay, there we go. So type 4 and type 5 are related to older grafts. So you don't see that much anymore, but that's just where you leak through the graft itself. Let's see. There we go. Rupture AAA. That's, our biggest emergency, and it's got the highest mortality of anything we do. It's, mostly a stat OR, so I think it's good to have a script in your head of what you're going to do and what you're going to expect from this sort of problem. So most common rupture site is left posterior lateral wall. 50% of the people make it to the hospital alive. 50% survive the operation, so that's an overall mortality, 75%. Classic triad is abdominal pain, pulsatile mass, and hypotension. In this day and age where CTA is so quick and it would allow the patient to have an endovascular repair, I would just get the patient immediately to the CAT scanner. Permissive hypotension is now a rule to make sure that the patient is mentating, so they don't have end or organ ischemia, meaning malperfusion of the brain. So for mentating, you don't give them blood, you don't give them fluid, just have massive transfusion available, and that's really one of the key components of management pre-op. And then stat OR, you keep the patient awake. As soon as they intubate and induce, they're going to drop their pressure when they vasodilate. And so, basically, you're either, if you're going to go open, you're ready for incision. You've already prepped the patient awake, and then you induce and intubate with incision. If you're going at percutaneous, you keep them awake until you have the balloon in the supraceliac aorta, and then you can put them to sleep once you have the balloon up in the supraceliac aorta. This is the quickest repair. You see a picture here, an EVAR, endovascular aneurysm repair with conversion to aorta uniiliac. So there's a tube from the aorta down to one iliac, the other iliac's occluded, and then a fem-fem bypass. And that way, the procedure is very quick. The complications are severe. The coagulopathy, renal failure, ischemic colitis, these numbers are all very high. So I tell people or family members, if you're having a ruptured aneurysm and you're coming in for repair, it's about 100% chance of a major complication. And then you have to assess for abdominal compartment syndrome before leaving. So if it's both open and endovascular repair, you really have to assess, talk to the anesthesiology, get the peak pressure. You can check the Foley pressure, but it has to be assessed before you leave. And if there is one and you did it endovascular, you can easily, release the compartment just by going through the fascia in the abdomen. Supraceliac clamp. This is for your rupture or any other vascular emergency that's below the diaphragm. But know these steps well, taking down the triangular ligament, retracting the lobe of the liver anteriorly, go through the lesser sac, to the gastrohepatic ligament, have anesthesia put an NG tube in, mobilize it to the left, feel the cruise to the diaphragm, you can mobilize and divide it. It's very thick. It's usually blind because it's bleeding, so you just run your scissors over your fingers and then put the clamp in the infrarenal position. Aortic dissection. Most of this is cardiac surgery because most of these are type A, which means going to the ascending aorta, and if it does, that's obviously an emergency. But the type B, the ones that go distal, the subclavian and down, can go all the way. It can go as distal. They go down to the femoral. So those dissections can be pretty extensive. It's usually patients that have hypertension or connective tissue disorders, and it's an intimal tear. And what this does, it creates an intimal flap that can occlude anything. It can include a coronary, it can include a mesenteric vessel, a femoral vessel, and it can cause ischemia. Also, the tear can cause bleeding, like a rupture, an aneurysm, or if it's in the heart, if it extends to the heart, a tamponade. And so this is all treated with anti-impulse therapy. So that means beta blocker first. And so you have to get the heart rate down 60 to 80, blood pressure to 100. And beta blocker must be first, so you don't have a compensatory increase in the heart rate if you give a calcium channel blocker. And then these are complex surgical management. I would say that TVAR is probably the most commonly performed technique for repairing these type B dissections. And a lot of the aorta is covered, so there is a high risk of paraplegia. That's a major complication. Popliteal aneurysms, we treat them usually when they get to around 2 centimeters if they're asymptomatic. If they have a lot of thrombus, you can treat them slightly smaller than that because, like I said before, the major risk is embolization. And here's a picture of a posterior approach, which is a short graft in between, interposition graft. You can treat it with a fem-pop bypass as long as you ligate the popliteal artery. And that's really it. I think the rule of 50 is what they usually push for this disease process, which is 50% of these aneurysms in the popliteal are associated with abdominal aorta, and 50% have a contralateral aneurysm in the popliteal artery, and also 50% that present with acute limb ischemia from a popliteal aneurysm have limb loss that's with surgery. So good to be aggressive about treatment with these. Here's the repair. You can treat endovascular with a stent. You do the posterior repair that I mentioned, that's number B, or you can do a fem-pop bypass, that's A, with ligation above and below the aneurysm. Splanchnic aneurysms, this picture just shows here the percentage of incidence. The splenic is the most common, 60% can happen in any of the arteries. Renal artery aneurysms, really the size criteria that we treat, is anywhere from 2 to 3, depending on risk factors. Pregnancy trumps all for this. If a pregnant woman has a abdominal or splanchnic aneurysm, you treat it at size 2 because the rupture risk is so high. But most people now are treating at 3 centimeters, the new consensus criteria. And then we'll move on to occlusive disease, the other major disease process that we treat. So best medical therapy, so not this. So you got to talk to patients about smoking. Even on the test, it'll say, what do you want to do first for arterial disease? That's atherosclerotic. You want to do best medical therapy. So aspirin, is a good way to start. If they're claudicating, you can offer them first Popliteal or pentoxifylline. And then other kind of vascular medications, just to note here, they did mention they wanted you to know about heparin dosing. There's the bolus dosing and the infusion dosing. And then Coumadin, as you probably remember, the factors that it blocks to cause anticoagulation. And what else here? And then heparin's reversed with crotamine. And it's usually in the OR. So the first kind of atherosclerotic disease fact that will start from the top of the body at the neck, with strokes, so cerebrovascular disease. It's the 5th leading cause of death in the United States, mostly due to the carotid, internal carotid artery, and it's usually atherosclerosis, although fibromuscular dysplasia and other diseases can cause stenosis as well. There are special considerations if people are symptomatic, or if they're having crescendo TIAs or stroke and evolution or mobile thrombus. You may want to treat them sooner. String sign, there's, I think, probably too much controversy about that. And Ica Occlusion, and it sounds like the worst of all of them, so you'd want to treat the soonest, but actually we don't treat Ica Occlusions at all. Usually it occludes all the way up to the intracranial portion, internal carotid, and there's no safe treatment for that, and they're protected from future emboli because they are occluded. Cerebrovascular interventions, I think they want you to know a fair amount about carotid surgery, indications, or symptomatic patients greater than 50%. and asymptomatic patients greater than 70%. The carotid endarterectomy is one way of treating it. You need to know whether you're going to routinely shunt someone or selectively shunt someone. The way to think about selective shunting, they might ask you if you're going to decide how to shunt someone. You have to use a well-established criteria to decide it. So either you shunt everyone, which is routine shunting, or you decide in the operating room if you're going to shunt them. And the kind of known ways of deciding that are accepted by everyone are stump pressures, which is putting a needle in the carotid artery when it's clamped and measuring the back pressure with an A-line setup, or you can do neuromonitoring, which is basically monitoring the waveforms and looking for slowing the waveforms during the procedure when you're clamped. Like I said, those are the most common, or you can do the surgery awake, and if the patient becomes symptomatic, then you shunt. Most people do patch angioplasty. The eversion is an accepted technique, and that's putting a patch, usually from bovine prosthetic or Dacron patch on the carotid artery after you're done cleaning it out. And then carotid endarterectomy. I think this is the only one I really mention at trial because they're so well established, and I think they do want you to know them. But here's the quick breakdown. There's two trials, NASIT and ACAS. And NASIT, the North American Symptomatic Carotid Endarterectomy Trial. If you're symptomatic and greater than 70% stenosis, the stroke rate without surgery is 26% in 5 years and 9% with surgery in 5 years. So a huge improvement. Even the 50 to 69% group also did well. 22% stroke at 5 years without surgery and 15% stroke at 5 years with surgery. So we treat everyone that's symptomatic greater than 50%. For asymptomatic, it's greater than 60%. There was benefit, and the stroke rate is 11% at 5 years without surgery and 5% with surgery. We don't want to get into why the numbers are different. They use 60%, one group uses 50%. It's just different ways that they're measuring. So, that group does benefit from it, the asymptomatic patients, but by the way we measure, I think for the purpose of the test, that if they're greater than 70% asymptomatic, then you would treat them. But the original trial was done with 60%. It's just measured a different way. And then carotid stenting, that's available now. You can go transfemoral, you can go transcarotid. The key for that is you must have some form of embolic protection, because when you deploy the stent, there's a very high risk of stroke from emboli, so you have to have a form of protection. And I think the complications are, again, well known for carotid surgery, and and really reliant upon your knowledge of anatomy. So it's a good test question. If the patient has a stroke, and it's obviously something technical immediately post-op, so you just bring them back to the operating room. You don't give heparin. You just open the patch. You flush the patch back. If it's completely thrombosed, you can do a thrombectomy with a balloon carefully up the internal carotid artery, and then you revise whatever went wrong, like an intimal flap or a patch suture that was misplaced. But cranial nerve injuries, I think, are well tested. You can see here the location of the vagus nerve right along the carotid artery. You can get clamps, and if that's clamped, you'll get hoarse. The hypoglossal nerve, which here is retracted up, is usually lying right over the internal carotid artery, kind of transversely, and so that's easily injured and can cause tongue deviation towards the side of surgery, so ipsilateral tongue deviation, and then that will cause hoarseness and that will cause difficulty swallowing. There's the glossopharyngeal nerve. If you're having to go really high and take the styloid process, there's a chance for injuring that. And a really proximal dissection. And again, that would cause difficulty swallowing. And the facial nerve, usually it's just retraction injury and causes drooping of the edge of the lip. And I think someone's asking a question about vessel loops and the ordering of how you clamp the vessel. I would say everyone has their own kind of technique, but most people put a clamp on the internal carotid artery distal to the lesion first, right? Because you want to protect the brain. So it just makes sense to think about it that way. You put a clamp on the internal carotid artery. Now you're protected. Then you go ahead and take the pressure off by putting a clamp on the common carotid artery, and then you can tighten your vessel loops or clamps on the external carotid and superior thyroidal arteries. Then you're going to do your surgery, and then you're going to flush everything. So it's back flushing, so you don't have to worry about the order. You can open the common, the external, the internal, any order you want, one at a time, flush the lumen. Then you're going to finish your patch, and this order does matter. This is probably the most important one, is that when you're going to reestablish flow to all of the vessels, you want to unclamp the internal carotid artery last. So you unclamp your common and external carotid. You unclamp your common carotid, external carotid arteries. Let there be numerous heart cycles and pump that blood up to the face. So if there is any debris, it'll go to the facial arteries, which are inconsequential. And then you release your internal carotid artery last, and that will prevent any emboli to the brain. Another good complication to know is hyperperfusion syndrome, which is headache and after revascularization of the carotid artery, and it's associated with hypertension. So headache and hypertension has to be treated. You have to decrease the patient's blood pressure because the intracranial arterial perfusion is too high. The arteries have not learned to vasoconstrict yet because they've been maximally vasodilated for decades probably. So it takes about a week for them to learn that, again, to be able to vasoconstrict. So you have to treat the patient's blood pressure, get it low, definitely in like 100 to 120 if they're having hyperperfusion syndrome, because eventually the headaches then progress to, microscopic intracranial bleeds from the high pressure. And that's really a carotid patch infection is rare. Peripheral arterial disease, claudication, I'm sure you're all familiar with, which is cramping in the legs with exertion, not related to, you have to make sure it's not pseudoclaudication, which is related to back pain, sciatica, which is claudication is a benign process, pseudoclaudication is benign, but the rest pain is when the ischemia is so profound that you have pain even at rest. It's basically like a resting heart attack at the foot because the pressure is so low.
Sorry.
So we call it metatarsalgia because the pain is in the foot. And then we can, patients also have tissue loss, which is gangrene and ulceration in the feet. So those are the different ways that we think about, that chronic critical ischemia. And then there's also a related disease, a different process, which is acute limb ischemia.
Yes.
And acute limb ischemia is from immediate occlusion of the vessels distal, which we'll go into a little bit more. But here's the graph that is Rutherford established, which is the types of acute limb ischemia and how to treat them. We'll talk about it a little bit later. So chronic critical limb ischemia, people have graded it here. You can just see mild, moderate, severe. It's all benign disease. And the rate of losing your limb with any sort of claudication alone is just 5% over 5 years. So that's 1% a year. So you don't necessarily need surgery. It's ischemic rest pain with tissue loss and ulceration that needs treatment. We've developed a Wi-Fi score, but it just means that if you have a wound, ischemia, and foot infection, you're more likely to lose your leg. They put this in a graph. Not that it's needed, but just knowing that those patients that have all three of those things are at highest risk for losing their legs. And then there's types of occlusions throughout the body, from the aorta down to the tibials. And again, we have the TASC criteria, which is saying classifying each type of occlusion or stenosis in the body and the different patterns and what they would be treated with. there's like, they classify it as type A, B, C, and D lesions. It's really just a bunch of people's ideas about how best to treat it. There's not really any data behind it, but what the idea is, and I say this just because I think they do ask you guys about it. A type A lesion is something that would be easily or would be best treated with endovascular because it's the anatomy is amenable to it. Whereas task D on the other side is something that would best be treated with open surgery. Now those things are I'm sure you've seen in hospitals too. That's not followed. Many task D lesions are treated with endovascular surgery. These are just guidelines. And then B and C are the intermediate ones where may be treated best with open or endovascular. There's no real, consensus there. But, so for straightforward lesions with, 1 or 2 occlusions, yeah, sure, endovascular would be fine. With multiple occlusions and multiple vessels, most likely you're going to need open surgery. It's pretty self-explanatory. Aortoiliac occlusive disease, how do we treat it? Covered stents in the iliacs are fine. Aortic bypass, gold standard operation. It works well. Make sure to tunnel the limbs underneath the ureter. That's a question that you might get. Basically, the limb is tunneled over the ureter, and then there's the ureteral obstruction from the limb on one side, the artery on the other side, and the ureter in the middle getting crushed. And they have good patency. There's many other surgical options for aortoiliac disease. For sicker patients, they could have axial Bi-Femoral, which is an extra anatomic bypass. And then I think I put this on there last year, but I think it's a good one because common question, at least that we get, is that there's 2 ways to do an aorto bypass proximally. You can just transect the aorta and do an end-to-end like you would for an aneurysm and anastomosis, or you can sew it end to side and but there's certain disease patterns that this would not work well with and is actually contraindicated. And so in end-to-end anastomosis, you cannot do that for the occlusion patterns that you see in patient number 3 because when you do an end-to-end anastomosis, there's no antegrade flow through the native aorta. There's retrograde flow coming back to perfuse the hypogastric. So if both external iliacs are occluded, the bypass takes the blood from the aorta, shunts it down to the femoral artery, and then it flows retrograde up the iliac. And if both external iliacs are occluded, then there's no flow to the hypogastric, and they can have buttock ischemia and colonic ischemia. So A and patient 3 are contraindicated. So you have to do B if you had a patient with that anatomy. There's axial Bi-Femoral bypass. Here's a picture of a graft sewn onto the axillary artery. The first portion just medial to the pec minor. And then you can do an aorto-uni-iliac. There's a little retroperitoneal incision where you can do a, aorta to iliac and, surgery, aorto-uni-iliac bypass. And then infrainguinal occlusive disease. Probably see this the most, but there's not really that much to say about it. Common femoral artery disease has to be treated with endarterectomy. There's no minimally invasive option. SFA disease, you can treat with stents or bypasses. Obviously, using vein is going to be better than graft. But if a patient has a short life expectancy, less than 2 years, graft is fine. And if you're going below the knee, the patency starts to drop off. And you definitely want to use vein below the knee because the patency with graft is much worse. Acute limb ischemia I mentioned before. The most common reason to have acute limb ischemia is no longer AFib, probably due to all the patients being on anticoagulation now and the DOACs. It's actually plaque rupture. So it's a atherosclerotic plaque that ruptures and you get distal occlusions and ischemia. You want to put these people on heparin and then treat them with either thrombolysis percutaneously or thrombectomy open versus primary amputation. And again, here's that graph of the different types of levels of ischemia that Rutherford made out when patients present. So if they have no sensory or motor loss, then they're type 1. You can wait and, do your workup and treat them, within, the week. It's not really urgent. But type 2A Rutherford is when they have sensory loss, and that's the first thing. So that defines 2A. So that is a threatened limb, and you do want to treat that promptly, usually within 24 hours. Lysis is fine because you have time to start lysis and then treat them over days. Type 2B is the most emergent, most threatened limb, and that's where you have both motor and sensory loss in the toes, and the sensory loss is going up to the foot. You want to treat this as urgently as possible. If you are doing lysis, you might want to do percutaneous thrombectomy as well. I think for the purpose of your test, I would say open surgery for this, or open thrombectomy. So, that way you restore blood flow immediately. Type 3 is when there's profound motor and sensory loss in the foot and ankle, and the leg is cyanotic, and this is irreversible, and the patients would do worse if you revascularize because of mobilization of all the cytokines. So this is primary amputation when the patient is amenable. And in this kind of disease process, there's also atheroma embolism, which is called blue toe syndrome. These patients have palpable pulses, but blue ischemic toes, and that's from microemboli in the capillaries. Really, it's just supportive care with aspirin and statin for this, but you do want to find the lesion that caused it. So you do an echo, and you do a pan scan, chest to pelvis, really chest out and pelvis, and run off the feet. So a pan scan. Popliteal entrapment syndrome. This is one of those non-atherosclerotic compression syndromes. Young patients without any atherosclerotic risk factors often have bilateral claudication and loss of pulses when they plantar flex, and that's the pathognomonic kind of key there. Loss of pulses with plantar flexion, and that's due to a congenital anomaly with the medial head of the gastrocnemius muscle, most commonly compressing the popliteal artery, and you just basically resect the medial head of the gastrocnemius muscle, and the popliteal artery goes back to its normal anatomic position, and the claudication resolves. Compartment syndrome, I think probably pretty commonly seen from you guys. It's a common disease process for us in vascular. It's from reperfusion. The muscles swell and compress the nerves to the point they become ischemic and non-functional. It can also happen with hematomas and trauma. But you can measure compartment pressures, but it really is a syndrome, so it's diagnosed clinically, and most commonly affected compartment is the anterior, and this is just a matter of just knowing your compartments. I outlined them in black. You can see here the anterior and lateral compartments. In the front is treated with that dotted line, an incision where that dotted line is between the tibia and fibula, and then the posterior deep and superficial compartments are treated with the fasciotomy of those two lines that you see there with the dotted line, just posterior to the tibia. And usually it's loss of sensation in the first web space, and that's due to the anterior compartment being so susceptible that it crushes the nerve, the perineal nerve. When you're doing a fasciotomy, just a point: if the patient post-op loses their ability to evert the foot, it may be because you did your fasciotomy a little high and you transected the deep perineal nerve, which is marked there. The superficial perineal nerve, which crosses and kind of from posterior to anterior, and so you don't want to go within 10 to 13 centimeters of the knee when you're going in that lateral aspect fasciotomy. You could cut that nerve. Lower extremity amputations, not much to say about it besides people tend to regain their functional status with a BKA versus an AKA. It's like 70% of BKAs walk again, where 30% of AKAs walk again. Not much else I can say about that. Graft infections, probably the worst disease process that we have because they're so difficult to treat, and you have to not only remove an infection, but also revascularize the patient most of the time. Infected aneurysms can happen to the native artery with, arterial catheterizations or percutaneous closure devices or drug abusers, or to the surgeries that we do. The grafts get infected. Some of the organisms that we see, most common is Staph aureus, actually, but the most virulent is Pseudomonas, so you most likely see that present, quickly with the sickest patient. And in terms of someone's prior question about rifampin soaked grafts, some surgeons I know are so worried about graft infections, they rifampin soak all of their aortic grafts. But if you're treating a graft infection, with a less virulent organism than Pseudomonas, yes, it is somewhat accepted to do a rifampin soaked graft. I wouldn't answer that on the boards. We'll go into the treatment here, but that is somewhat accepted. Staph aureus is most common, Pseudomonas most virulent. Streptococcus usually presents really late, and they have just weight loss, malnutrition, malaise, and then eventually you see they have an infection. Someone had a question about when the imaging workup. So that's the next one here. So you have those symptoms. You suspect graft infection. A CTA is really the best. You can, like the person mentioned, get a tagged white cell scan. A little bit difficult because sometimes grafts tend to have a lot. They light up on tag scans anyway, but just because of their inflammatory nature. But that is okay. But air is the pathognomonic finding for a graft infection. So if you do a CTA and you see air anywhere in the graft, that means it's a graft infection if you're more than a month out from surgery. You can get blood work and everything else, but that's really the pathognomonic finding. This is pretty severe arterial infection that you see here. Aortic fistula is another type of graft infection. You can do a scope. You see here some graft coming in through the through the bowel. You see it really penetrating all the way through it. It's usually if someone has symptoms of graft infection and they've had prior aortic surgery, particularly endografts or Bi-Fem surgery, and they tend to erode through the duodenum, jejunum, as you saw in that picture of that surgeon holding the duodenum for the aortic repair. It sits right back down on the aorta. So that's the most feared consequences is that it erodes, the vascular graft erodes into the bowel and then bleeds, so they can have massive aortic fistulas with bleeding that need to be controlled. And here's some of the surgeries that you'll see to do that. Obviously they're going to need medical treatment, antibiotics, but you have to excise and revascularize. So how do you do it? For the boards, it's actually the last option is the most accepted kind of board answer, and it's excising, or it's first doing extra anatomic bypass, so that's an axial bi-femoral bypass, and then keeping them on antibiotics either that day or the next day, excising the graft. So then going into the belly and ligating the aorta, proximal and distal, removing the graft and any infected tissue. And that's that. Here's another way of doing, instead of extra anatomic bypass, you can take the deep vein and make a neo-aorta, pretty exotic. But this is the most common. Here's an axial bifemoral bypass. You see here on a CAT scan coming from the right shoulder down to the right groin and then crossing over to the left groin. And then the aorta is traced here, and you can see someone put a line on the aorta, and then it ends right distal to the left renal, so it's been ligated. That's treatment for graft infection of the aorta. Renal vascular disease, a lot of medical questions for it, but very little surgery involved. Usually patients with renal vascular atherosclerosis have hypertension, impaired renal function, and even flash pulmonary edema associated with high risk for cardiovascular events. Their chronic kidney disease and atherosclerotic disease, they tend to have heart attacks. I'm not going to go over the RAS system. You guys probably don't want to hear about that. And here's ultrasound we use to diagnose it. There's all sorts of tests you can do to measure for renal vascular disease, but mostly ultrasound is the most commonly used one today. And then the treatment, you really only treat this disease if they have uncontrolled hypertension despite 3 maximized antihypertensive medications, or they have flash pulmonary edema. So it's really pretty limited indications now, whereas it used to be everyone got renal stents. And all sorts of ways to treat it. These are all pretty exotic surgeries. You never see these anymore because everyone gets this, a renal stent. And one kind of disclaimer, if the patient has renal stenosis from fibromuscular dysplasia, you cannot put a stent. They'll do much worse than restenose, just angioplasty or open surgery. And then if we could just quickly do thoracic outlet syndrome, because I know they test you guys on it so much because there's so much anatomy to it. Thoracic outlet syndrome is a compression syndrome. The thoracic outlet's bordered by the first rib, T1 vertebra, and the manubrium. And there's 2 triangles here, the venous triangle and the interscalene triangle. So you can kind of see here the venous triangle right between the subclavius, the first rib, and the anterior scalene. So that's the venous triangle, and that's where the vein can get compressed. And then just posterior to that anterior scalene, you see that red artery there, and then you see the brachial plexus. So that's the order. And they're always questioning on the order. So it's vein, going from anterior to posterior, vein, anterior scalene, muscle, artery, nerve. And then there's that posterior triangle. So any of those can get compressed. So it's most commonly the nerve gets compressed. It's 90% of these patients. Then vein, and those patients tend to get DVTs in the subclavian axillary vein. And then arterial, which they have, symptoms of pain and white fingers from arterial compression. Okay, 2 primary ways of treating it. I do transaxillary. This is the view that you're going to see, and this is the relevant anatomy. And when you're going transaxillary, you'll see he's got a little vein retractor on the subclavian vein. He's got his right angle all the way around the anterior scalene, ready to ligate it so that you can free it. And then next, behind that is the subclavian artery and brachial plexus. In this view, there's really not much for nerve or anatomy. That's why I like it. You just take the rib out. The supraclavicular, tons of questions I'll probably ask you about this one because there's tons of relevant anatomy things you have to watch out for. You'll see internal jugular, the most kind of anterior medially, and then you're going to see a nerve crossing across the anterior scalene, and it's the only nerve in the body that goes lateral to medial, phrenic nerve. Right, so you don't want to ligate the phrenic nerve. You take the scalene muscle behind that, and then you're going to go and you're going to start to free up the middle scalene, and just posterior to the middle scalene is the long thoracic nerve. So you don't want to ligate that. That's the posterior extent of your dissection. Then you take the rib out. So that's the order, and those are the relevant nerves. I think that's really all I could ask you about that. Yeah, I mean, those are the different treatments. But one other thing they tend to ask about venous thoracic outlet syndrome. I know I hear from other people, and that is the management of venous thoracic outlet syndrome. I mean, neurogenic and arterial. Neurogenic is physical therapy, and then take out the rib for them if they don't benefit from that. Arterial, if they embolize, you have to treat it with a cold arm and declot the arteries and then take out the first rib. But venous is the most kind of questionable one. They have a DVT. A lot of people just want to anticoagulate, but really the treatment is that you thrombolyse the vein. So you put a percutaneous thrombolysis catheter in, take out the clot. You can drip in TPA. So open the vein, and then what they want is you to do is on that same admission take out the first rib. That's not always done in practice, but that is, the board answer is early surgical intervention. So, take out the clot, put them on anticoagulation, and in that admission, take out the first rib. I think we're out of time, and that's all right, because, we really just have, fistulas. I don't think there's much fistulas. You guys can kind of read through the charts here, and you'll probably hear a little bit more about trauma in that section. but some basics about trauma here, and that's it. Any questions for me? I know they've been kind of coming as we're going, but any last minute questions, or you can email me if you send out my email, and you guys can send anything.
Thanks, Dr. Botta. That was excellent. Any last minute questions for Vascular? Okay, so we have about, again, thanks, Dr. Botta, for coming this morning.
Yeah, thank you.
We